I've been staring at it, but I shouldn't brush her ears and I just didn't bother. Really hasn't done it.
Irritable bowel disease. Irritable bowel disease. Okay? So what do we want to do if somebody has irritable bowel disease? We want to collect data. We're going to collect our data about the patient's age, about their gender, and about their culture. Because sometimes the types of foods that we eat may be related to our culture. Okay? This information can be useful in assessing who is likely to develop a GI disorder or symptoms of a GI disorder. For instance, older adults are more at risk for stomach cancer than are younger adults. However, younger adults are more at risk for an inflammatory bowel disease. We don't know the exact reason why that is, but we are doing studies at this time so that we can come up with some type of evidence-based information that would let us know why. So, here we have the two disease processes, and when they're looked at by your GI doctor under the scope, this is kind of what you're seeing, or this is what he's seeing in order to be able to make this diagnosis. We're going to talk first about ulcerative colitis. We'll talk about that, then we'll talk a little bit about Crohn's. How I want you to set up your study notes. We're going to start with ulcerative colitis. I'll give you the narrative on what I'd like to say about it. Then I'm going to come back and I'm going to sum it up. So leave you a spot for each disease process. Ulcerative colitis creates widespread inflammation located mainly in the rectum and rectosigmoid colon. Those are mainly the places, but it can extend the entire colon, the rectosigmoid colon. Okay? When you look at your diagram, look at where you can see that rectosigmoid area, where it joins. Okay, but the thing about this disease, though, it can also extend to the entire colon if it becomes extensive. If the disease becomes extensive, it can go through the whole colon. The disease remains constant for years. Ulcerative colitis is associated with periodic remissions. This is important. Remissions and exacerbations. Ulcerative colitis is associated with periodic remissions and exacerbations. What are these called? Think about the commercial. What is it called? Flare-ups. Flare-ups. Right. They have flare-ups. Sometimes something as simple as an intestinal infection can cause a flare-up. continuing with ulcerative colitis. Most patients who are affected have mild to moderate disease. They have mild to moderate disease symptoms, but there are 10 to 15% of patients who present with severe symptoms. 10 to 15% of people have severe symptoms. Now, people like me who are old folks like me, are at risk for fluid and electrolyte imbalances, okay? They're more at risk for fluid and electrolyte imbalances. Why? Because of the diarrhea, absolutely. They are also at risk because of dehydration. You got diarrhea, you're losing fluid, you're going to get dehydrated, and also hypokalemia. So the older people with UC are more prone to fluid and electrolyte imbalances because of diarrhea, because of dehydration, leading to hypokalemia. Abscesses can form in these ulcerative colitis areas. Ulcers can form, or abscesses can form. You get an abscess, and then you're going to have tissue necrosis. Cells are going to die in these areas, and you're going to end up with tissue necrosis. Okay. If it continues to become a problem, you could end up with a narrowed colon. A narrowed colon, which can lead to bowel obstruction. All right, that's it on UC. That's it on UC for now. We're going to talk about nursing management and all of this stuff in a bit. But I want to go down to Crohn's, since it's kind of set up on the PowerPoint with Crohn's versus, see how ulcerative colitis versus Crohn's. So I'm going to talk to you a little bit about Crohn's now. It can affect the GI tract from the mouth to the anus. Most commonly affects the terminal ileum. Okay, the terminal ileum. This disease is slowly progressive, and it can be unpredictable. Multiple organs can be involved. Also, the disease is similar to ulcerative colitis in that there can be remissions and exacerbations. Those are the ways that they're similar. Remissions and exacerbations. So with Crohn's, the doctor will say that the bowel is thickened. The bowel walls are thickened. He will see strictures and deep ulcerations. What is the hallmark appearance of what is it? Cobblestone? Cobblestone? the bowel, I'm sorry, the bowel is going to look cobblestone in appearance. Like a cobblestone street. If you've ever walked down a cobblestone street, it'll be bumpy. Like little rocks and bumpy. Okay? So these patients with Crohn's are at risk for fistulas. They're at risk for fistulas. Yeah, I may have talked about things like that. This one here does similar. 2 organ structures. Developing a fistula. The result of Crohn's, again, is severe diarrhea and malabsorption of vital nutrients. Another issue with them is that they will probably present with anemia. Anemia is common in these patients. Iron deficiency. When assessing or inspecting the abdomen, assess for distension, masses, listen for paracelsus, talk to the patient about their bowel habits. During auscultation of a patient with Crohn's disease, you may hear an increased high pitch or rushing sound. Usually these patients will report diarrhea, abdominal pain, and possibly a low-grade fever. If they have fistulas, we talked about them having fistulas, right? If they have fistulas and they say that they have a fever, we put those two together. They say I have a low-grade fever, then I'm going to be looking for fistulas, okay? Because of all the infection, the inflammation, the body trying to compensate for all of what's going on. This is important to note. If the disease is in the ileum, if the disease has progressed to the ileum, what are you going to see? You're going to see 5 to 6 stools per day. Those stools are going to be soft, they're going to be loose, and they're going to be fatty. And they may also contain bright red blood. Now, my patient with Crohn's disease. My patient with Crohn's is going to need a psychosocial assessment. So they will need a referral. We'll need to refer them to someone else because of the chronic nature of the problem. Okay? And the complications that go along with it. They can be embarrassed, having to run to the bathroom constantly. You know, especially if it's new to them and they're not able to adjust themselves. It can affect their family as well as the patient. Lifestyle changes are going to be necessary for them to cope with such a disruptive and painful chronic illness. So we are assessing constantly when we're speaking with them, we're assessing their coping skills. We're going to help them identify support systems support system. Because clinical depression and severe anxiety in these patients have led to suicide. Some of these patients will commit suicide because of the debilitating process of this disease. So now, let's go back and let's go to ulcerative colitis. Sum it up. We gotta sum it up. Okay. Usually, the age group that is most affected by ulcerative colitis are usually in the age range of 15 to 25 years of age. 15 to 25. And then it peaks. And it may be, the range in the book may be a little bit different, but it peaks around age 50 to 80. Around age 50 to 80. And that's just statistically what has been observed by clinicians. And it doesn't discriminate. It doesn't discriminate among the sexes, okay? Male and female can be affected. However, it doesn't discriminate, but in women, it is found to have a higher instance or a higher incidence. So now, when we talk about cultural, and we talk about who is affected more so than others, if we live in urban areas, you may find that an urban population of people, upper middle class people, Jewish people, may be affected more so with ulcerative colitis. So these people will come to us and they will say that they have bloody diarrhea. They will present with bloody diarrhea and abdominal pain. Their pain may be mild to severe. The most important thing about this is to understand, as far as ulcerative colitis is concerned, if the disease is mild, if they're in a mild state, they probably will have 1 to 2 stools, 1 to 2 semi-soft stools a day. If it's moderate, they may have 4 to 5 stools per day. 4 to 5. And then the bleeding is going to begin to get worse. This is in the moderate stage. In the moderate stage as well, they may have fever, malaise, and there may be some anorexia. It is not uncommon, if they are having a severe episode, to have 10 to 20 stools a day. 10 to 20 stools a day. So you can imagine how someone would feel. They're in the bathroom more than they're out of the bathroom. They can have as many as 10 to 20 stools. I want you to understand the severity of these illnesses. So if your doc says that your patient has UC or Crohn's or something of that nature, understand the severity and what these people go through. Sometimes they can't even go out with friends Just like that's true. When you see them on these commercials, they're not just saying that or showing that just to be showing something. It's true. These people have to go to the bathroom constantly. They have to watch what they eat constantly. And it can be life altering and limiting and depressing. Okay? Fever, when it's severe and they have those 10 to 20 stools, fever may be there, weight loss, of course, dehydration. So with all of that being said, as far as ulcerative colitis goes, we know because we have gotten to that area where we know that complication is hemorrhage. They bleed, they're going to hemorrhage. They're constantly having those acidic stools and such. There's going to be strictures. Strictures are going to be fissures. Strictures are going to be. Thank you. A complication could be perforation. But more than anything, that toxic megacolon, which is a dilatation and paralysis of the colon. Yes, the toxic megacolon. So the colon dilates, but it also is peristalsis is taking place as it dilates, and it's called a toxic megacolon. So, what kind of studies? What kind of tests? What kind of imaging studies? Colonoscopy. Absolutely. They'll do a colonoscopy. Fiber optic colonoscopies. They'll do maybe a sigmoidoscopy. Okay? So, endo. Patients are going down to endo. You may order a barium enema. Barium enema. And of course, we're going to do a CBC. We want to know what's going on there. WBCs, H&H, all of that good stuff. We want to know about it. Okay. If the patient, collaborative care, other things that we can do, if it's mild to moderate, these people aren't as severe as the severest, in which we said they're getting up to 20 stools a day. If it's mild to moderate, we're going to talk to them about a diet. A good diet for them might include low roughage diet. And we're going to say no milk. Let's cut down on the milk and the milk products, probably. That's not a good thing for us. So they may have to have an antimicrobial, some type of antimicrobial therapy. Steroids might be something that they might have to have. Corticosteroids. Anti-diarrheal agents, according to the doctor's orders. Anti-diarrheal agents. So continue collaborative care. Our patient has gone through the mild to moderate stage, and now they're severe. They're in the hospital. What are we going to do? We're going to hook them up, right? We're going to hook them up to some IV fluids. They got to have some electrolytes and IV fluids. And they may need to have a blood transfusion. Diet status is what? NPO. Diet status is NPO. NG tube to low suction. Because sometimes, keep in mind now, take it and put it all back together, they may present with that swollen belly, all that different thing going on, so the doctor may put them to low intermittent suction. These patients may have to have TPN because they've lost a lot of nutrients. So we've got to figure out a way to get some nutrients back in them. So it's very appropriate for our severe patients to get TPN. So see where you all will see TPN, if you've gone through the PowerPoints and gotten toward the end, you're going to see TPN toward the end. I probably would have put something a little bit, added it a little bit differently in there so you can put those puzzle pieces together. And that's one of the reasons why I wanted to do it this way, because I want you to see how that ties in. TPN for GI, okay? Ties in with these people who are having severe issues. If we can't get these patients managed through a conservative route, and I know that IV fluids and electrolytes and giving blood is not as conservative as we may consider, but with this disease process, it is as conservative as we can get, so therefore, we may have to do surgery. And some of the surgeries could include a total proctocolectomy, don't try to say it 3 times, or an ileostomy. Let's just say an ileostomy. They may have a permanent ileostomy. They may have to have a total colectomy. Who knows? Some of those procedures that may have to be done in order to manage. So what will happen here again? Body image. Body image disturbance, nursing diagnosis. Altered nutrition. Less than body requirements. Nursing diagnosis, impaired skin integrity, nursing diagnosis, ineffective individual coping, ineffective individual coping. And I'm going to give you one more. Nursing diagnosis. Ineffective management of therapeutic regimen. These patients sometimes cannot manage themselves. They cannot manage themselves, and especially if they're elderly. Just imagine you have an elderly loved one and they are constantly going all the time. Caregiver burnout, that's what I think about. Caregiver burnout. The patient is already having a hard time, and family member too. So the goal, what's the goal? What's our goal? Our goal that our patients will have a decrease in the number of acute exacerbations. That is our goal for this patient. We've already said how we're going to do it. We said we were going to teach them. We're going to talk to them about their diet, right? All of those things that we need to do in order to get them to the goal and try to help them to cope. We're going to help them to maintain a normal fluid and electrolyte balance. That's our job. We got to help them do that. We got to keep them in balance. It is also our job to help keep them free of pain and discomfort. They need to be free of pain, free of discomfort. But more than anything else, we need to stress to them the importance of complying with their regimen. we're gonna go over now and we're gonna fill in on our Crohn's disease. Let's go back to Crohn's. We'll fill in on Crohn's. Okay, so on Crohn's disease is a chronic, nonspecific, inflammatory bowel disorder of unknown origin. Now, Crohn's disease can infect or affect any part of the colon. Again, they're similar, so it's always a good idea to look at these PowerPoints and look at them and see and make sure to do the Crohn's versus UC. And pick out all the things that are different. Those are the things that we want you to look at. What's different about this one, or what's similar about this one, but more so, what's different about them, okay? So it's a chronic, nonspecific, inflammatory disorder, again, of unknown origin, affecting any part of the GI system. So we said that this disease can start and most often begins with younger age people, ages 50 to 30, kind of similar. May occur most often in ages 15 to 30. When it occurs in our older people, it's more likely that they're going to die. Here's a difference. The incidence of Crohn's is lower than ulcerative colitis. That's a difference. And the thing about Crohn's disease is it's sneaky. It'll sneak up on you, you know? It's insidious. If you've heard this before on some other disease processes like cancer of the stomach, it's insidious. Like that scary movie, Insidious. I like horror. The onset is usually insidious with non-specific complaints. Non-specific, we hear this a lot. Diarrhea, fatigue, abdominal pain, weight loss, fever. That could happen in a lot of disease processes, right? So unless we do the work and get the labs done, we don't know exactly what's causing it because it sneaks up on us. It's insidious. Okay? So these patients may complain of diarrhea. They'll usually say, you know, my diarrhea, I feel tired, I have some abdominal pain, I've been having some weight loss, I'm having a little bit of fever, you know. They'll say they have the diarrhea, but their diarrhea is non-bloody. Think about it. UC versus Crohn's, right? So they may complain of diarrhea, and that diarrhea may be non-bloody. It is a result of inflammation processes and malabsorption. So now, for Crohn's, for people with Crohn's, they may say that their pain is severe and it could be intermittent or constant. So we want to get specific with them when we talk to them about their pain. We want to ask them, are you having pain all the time? Or is it just every now and then? Is it when you eat? We want to get really deep into what's going on with them so that we can get them diagnosed correctly. Okay? They may say that they are having some cramping. When you go to palpate, they may complain of some tenderness. Again, you may find that they'll say, I've been having some weight loss. I've been having some issues with my weight. Dehydration may be an issue. When you look at your lab, you may see some dehydration. Electrolyte imbalances could be an issue for you too. Anemia might be another issue. So I would expect, if my patient has been diagnosed with Crohn's, I'm going to expect my doctor to maybe order us some order a CBC. I need to get a CBC. They may not complain of bloody diarrhea. However, the doctor's probably going to want to do an occult blood. Okay? Probably going to want us to do that for them. And there again, only because we're dealing with endo, we'll probably send them down for a colonoscopy as well. Okay? So they'll have a colonoscopy. And in addition to that, in order to do our diagnosis, they'll probably go ahead and do a biopsy. Get a biopsy, okay? So we can get a definitive diagnosis. So what's our job? Our job is going to be to talk to them about how we can get some calories in them. We need to get them a diet that's high in calories. We need to get them on some vitamins. We need to get protein. They need protein, okay? So here we have a diet that is high in calories, high in vitamins, high in protein, with low residue, and milk-free. The doctor may also order some type of antimicrobial agent for these patients. Drug therapy is going to include corticosteroids. These patients may also have TPN order. They may need TPN. Remember we talked about emotional support. We'll do the same with them. We'll do consults. We'll talk to our social workers, see if we can't get them set up with someone who can support them emotionally. Now, nursing management, similar to that of ulcerative colitis, okay? Nursing management, similar to that of ulcerative colitis. That's the reason why it's so important to put the two together and do your verses, okay? That's going to be the best advice I can give you on those in order to distinguish what's different and what's similar. As the patient improves with Crohn's, the nurse should allow for more self-care. She needs to start getting the patient in a place where they're able to care for themselves. Okay? Make sure that they have frequent rest because they need to rest. And also emotional stress. Emotional stress. Sometimes when you are stressed and you have this disease process going on already, then it's going to cause you to have to run to the bathroom, right? So we need to talk to them about that. Also, we need to talk to them about liver involvement. What could happen there? What's gonna be different? We're gonna look at those labs. This is gonna be us as the nurse looking at those labs and making sure that we understand that the diagnosis could be based on what's going on with their labs. Okay? For the CBC, anemia. Anemia is going to be the thing we're going to be looking at. And that's going to be because of the blood loss or the malabsorption. Okay? iron possibly, folate, B12. Those are some of the medications that we may need to supplement. And like we said, in TPN, usually it has everything that you need in there in order to supplement what they're losing in the gut. Because B12, of course, it is absorbed in the gut. So if we can't get it absorbed there, then we need to, get it in other ways. Okay. The CBC also will show us if there's any kind of infection going on. So we need to know what's going on with that. Okay, and then your SED rate. Your SED rate is also going to show you if there's some type of infection that may be going on with these patients. So those are some things that we can look at on the CBC. We talked about your toxic megacolon, what you're going to see, how it works. So be in tune to what could possibly be happening with a toxic megacolon. That's important, okay? Okay. So this slide here just kind of shows you, we talked about the fistulas, and it's nothing like being able to see a visual of what's going on with the patient, okay? So you see how there's that anorectal ulcer that we talked about, and then see how that fissure comes down, and it's kind of coming out to the opening. Just imagine you've already got a situation with diarrhea, and it's causing the patient some problems, and then you have those fistulas or fissures there. So you're going to have the burning, you're going to have the irritation, you're going to have the pain. And remember we talked about skin integrity. So that's important, especially with our elders when they can't care for themselves. We need them, or we need to be able to provide meticulous skincare. Okay. And this just sums up our treatments that we're going to provide for these patients. They'll get antibiotics, immunosuppressants, anti-diarrheal agents, and we've already discussed all of the medications that are important for the patients that are suffering with some type of GI issue. Okay. A colectomy. Here we have your surgical removal of the large bowel, which is more than likely going to be what the doctor will do with these patients, but not in the case, there again, as it says, for Crohn's. They may do some other tests, and they may do some other procedures with those types of patients. So now we're going to talk a little bit about, we're going to move forward, and I want to talk about peritonitis. This is so loud, so we're not going to go into that. We're going to talk about peritonitis right now, okay? So let's do a scenario. Here we have Timmy. Timmy is walking in a deserted highway. He's on a deserted highway one night when he is mugged. Okay, Timmy is mugged. He's mugged by two men, and he's stabbed in the abdomen. He was found later in the morning and was brought to the emergency room and was examined by a physician. Upon the examination, the abdomen is extremely tender and distended. The muscles are now rigid, and Timmy could not even feel the pain anymore. So he had gotten to the point where he doesn't even feel the pain, okay? His lab results show an elevation in his WBCs and alterations in serum electrolyte levels, okay? He was diagnosed with peritonitis as a result of his stab wound. So think about it. He got stabbed, and now he has a diagnosis of peritonitis. Okay. Appendicitis and diverticulitis can also lead to peritonitis, so keep that in mind. All of them are an acute inflammatory intestinal disorder. So there we have it. Peritonitis is an inflammation of the peritoneum the serous membrane that is lining the abdominal cavity and covering the viscera. Okay? Usually, it is a result of a bacterial infection. The organisms come from diseases of the GI tract or in women from the internal reproductive organs. So let's talk a little bit about the pathology. Peritonitis is leakage. It's like a leakage. It's caused by a leakage of contents that come from abdominal organs into the abdominal cavity. Okay? There can be a proliferation of bacteria. Proliferation of bacteria can occur. Then you'll have edema. Edema of the tissues occurs and exudate of fluid develops in a short time. All of this happens in a short time. You have this opening, you have fluids, it's an invasion. The fluid is causing an invasion, okay, of the peritoneal cavity. It becomes full. The peritoneal cavity gets full of increasing amounts of protein, white blood cells, cellular debris, and blood. So when all of this happens, what is the response? The immediate response is that there's going to be hypermotility in the gut. Then you're probably going to have a complication of a paralytic ileus. Y'all will hear that. You'll have a possible paralytic ileus. Okay? You'll feel that rigid abdomen when they have peritonitis. When you do your assessment, their abdomen is probably going to feel board-like and rigid. Okay? So again, we talked about causes. The causes are going to be injury, inflammation, bacteria, injuries such as a gunshot wound or a stab, just like Timmy, he got stabbed. Okay, inflammation, when there is inflammation that extends from an organ outside, it's going to extend from an organ outside the peritoneal area, such as the kidneys. They can cause peritonitis. Bacteria, such as E. coli. You know, we have E. coli in our system anyway, but if there is some type of opening and allows this to escape into the peritoneal membrane, then we can end up with peritonitis. Okay? Strep can also cause peritonitis. So you have certain bacteria that can contribute. E. coli being one of the most important, and strep. So now, what is your patient going to present with? What are you going to see when that patient presents to the emergency room, if they make it through? Okay? So symptoms are going to depend on the extent of the injury, whether it be from a gunshot wound or inflammation or bacteria, and the location. Okay? So if I'm assessing my patient, what am I going to see first? What will I see? Pain. Well, in Timmy's situation, because Timmy had been out so long, it had gotten to a point where his pain was so bad until he couldn't feel it anymore. It had gotten so bad. But pain is going to be first thing. If they're right here with you in the hospital and you suspect there may be some kind of perforation or something of that nature, you may see or you may hear your patient is going to say, I'm in pain. And man, the thing about it is they're in pain if they got appendicitis, they're in pain if they got pancreatitis, they're in pain. So, how do you tell it's just gonna be that assessment that, usually in cases like this, it's not gonna be something that you're gonna be able to catch at first. It comes over time. And a lot of times, usually it's like the example I gave you with Timmy coming into the emergency room and presenting with the symptoms that he presented with is the reason why you're going to have that nurse and you're going to have that ER doctor already saying, I think this is what we got going on. And then they're doing what they need to do in order to take care of that patient, because the first thing is pain. It's going to be diffuse pain. It's going to become constant. It's going to be localized. It's going to be more intense. Okay? It's like a pathological process that's happening with the patient. It's pain. It becomes more intense and more intense and more intense until it gets to a point of where you can't even feel it anymore. It's so intense. He'll be tender. You'll feel tenderness. It'll be tender. The stomach will be tender. And he'll be distended as well as being tender. You'll see the signs. You'll see that swollen abdomen. Okay, all of that will be there. And again, like we said, they become rigid. I call it, the way I remember it is they're rigid with pain. Okay, when they have peritonitis, they're rigid with pain. Moving these patients around can aggravate the symptoms further. Yesterday in clinical, moving a patient around made the symptoms worse. It was like, we could hear hollering from one end of the hall to the other end of the hall. And it was a similar diagnosis. It was a similar diagnosis. Okay? The vital signs could present. These patients may have, and this is another little insidious problem with peritonitis, in that they could be presenting at 98.6 up to 101. They could have fever, could not have fever. It's all in where the location of the situation is, how far it has progressed. So you may or may not see fever. May or may not. But you will see an increase in their pulse rate, so that's a help. You'll see an increase in the pulse. And as that increase in that pulse happens, that blood pressure is decreasing. Increased pulse, decreased blood pressure. So, the reason why this is an emergency, the reason why this is an emergency for these patients is because sepsis in the blood, sepsis, we don't want that to happen to these patients. We don't want them to go septic on us. Because the minute they go septic on us, there's an opportunity for death. There's an opportunity for death. Shock first, death second. Complication, sepsis, shock, intestinal obstruction, bowel adhesions, Okay. Diagnostic findings. Okay. Starting down here on the bottom. Diagnostic findings. We're going to be looking at the WBC will be increased. White blood cell counts will be increased. A hallmark sign is that they are almost always elevated. Almost always elevated. Okay? You decide you going in the ER, that doctor's going to be yelling orders at you. He needs that serum electrolyte study done. He's going to need that potassium, that sodium, that chloride. He's going to want to know what those numbers are. You're going to be yelling them back to him. This is what lab has for me. This is what we're seeing. Okay? Then, of course, they're already there with their abdomen and it's rigid, so you know they're going to get a flat. They're going to get a flat effect. They're going to look at that X-ray. They're going to have them come down there. And what it's going to show, that X-ray is going to show that there is going to be air and fluid in that distended bowel loop. Wherever that distension is, you'll see it on the X-ray as air and fluid. Air and fluid will be in that area. Okay? If he orders an abdominal ultrasound, the abdominal ultrasound will probably reveal an abscess and fluid collection. A CT scan. Now he's going to tell you to get a CT scan. That CT scan is going to show that there is some kind of abscess that's forming. Okay. And so he's going to say, lastly, I want you to get me an MRI. Get me an MRI so we can check to see if there is any abscess. So the CT, the MRI will show that. An abdominal ultrasound will show some abscesses. Okay? So all the while you're in the ER, you're taking care of this patient, you will expect, all of you guys that love adrenaline, that's planning on doing that ER rotation, I commend you. Doc's going to be saying, he's going to be hollering out that he needs fluids and he needs colloids. He's going to say, I need colloids orders. Colloids. He's going to say, I want to do some electrolyte replacement. Okay? Sometimes colloids, you know, back in the day we used to say colloids. We used to call it, like, what do you want, some blood? You know, you want some blood? Give me some colloids. That was the old docs back then in the day. So yeah, so we're gonna have that. We're gonna get fluids again. Doctor's gonna order some fluids. It's probably gonna be an isotonic solution. Probably gonna order an isotonic solution. Several liters. Several liters. They're gonna shoot some pain meds. Get some pain meds going. More than likely, intubation. These patients are more than likely going to be intubated. Okay? Intubation. Oxygen therapy. Right up there. Oh, he's saying the same thing that's on PowerPoint. I hate that. Don't y'all hate that when we read off the PowerPoint?
Yep.
It doesn't add to my originality. Antibiotic therapy. Antibiotic therapy, because peritonitis is going to have all of this nasty stuff going in places where nasty stuff shouldn't be. Okay? So nasty stuff shouldn't be there, and that nasty stuff can infect other things that we don't want infected. Surgery. Surgery may be something that we need to have done. Okay? But the most important thing is making sure we get all of those orders taken care of for the doc and taking care of the patient's pain. Okay? foreign, the first thing we want to do, get the pain taken care of, and knowing that peritonitis is a medical emergency. It's a medical emergency, nothing to play with. We gotta get them taken care of. Reduce pain, restore fluid and electrolyte balance, prevent complications. I'm telling you the things that are important for us. Reduce pain first. Restore fluids and electrolytes. Prevent complications. We have to somehow, in all of our glory, promote normal GI function. We got to get normal GI function back. So in our care, that's going to be first on our list of things to do. First, second, third, or fourth. Pain first. Monitor their blood pressure. We don't want them to drop on us. We don't want that blood pressure to drop. Okay? Meds.